Eric Winsberg and John Symons, nice to see you.
Good to see you again.
Welcome to everyone in the Sophia audience, meaningoflife.tv, bloggingheads.tv. The Sophia program is available on streaming video and audio podcast. I'm Dan Kaufman, the host. I'm also a professor of philosophy at Missouri State University. I publish an online magazine called the Electric Agora. I'm joined today by two gentlemen, both of whom work in the philosophy of science, and who, if you don't mind, could you give a little brief introduction, each of you, of yourselves, so that the audience can have a better sense of who you are, what you do, what you work in. John, why don't you go first?
Great, thanks, Dan. My name is John Symons, and I'm a professor of philosophy at the University of Kansas. I'm also external faculty for the Complexity Science PhD program at the Lisbon University Institute. And that's me. I work on modeling and lots of other things, but over the years I've written and researched on modeling and the use of computers in science.
Eric, why don't you give us the 30-second version of what you do and who you are, what you do, and what your areas of research are.
Thanks for having me on, Dan. So I'm Eric Winsberg. I'm professor of philosophy at the University of South Florida. I'm in San Diego right now. I'm visiting the Institute for Practical Ethics at the University of California, San Diego. I've been working on computer modeling in general in the sciences for most of my career, for about 20 years. I wrote a book called Science in the Age of Computer Simulation about 10 years ago, and since then I've mostly been working on climate science, and I wrote a book called Philosophy and Climate Science. It came out in 2018.
Well, this is great. The occasion of this, so John and I had already started sort of a budding relationship online because we're neighboring states, and we were trying to get something going where John would come to Missouri State to do some sort of a presentation, and then various catastrophes with my very, very old parents kept interrupting. But John reached out to me now because given the current situation with the novel coronavirus that we find ourselves in, John wants to talk. John and Eric both want to sort of bring some of their expertise and research to bear. And so John reached out to me to see if we could have a conversation about what modeling is, the kinds of modeling that are being used in confronting the novel coronavirus, and the relationship between such modeling and the sort of policy decisions that have to follow from it. I'm going to play primarily a moderator role. I may ask questions where I think that they might be illuminating, but for the most part, this is going to be John and Eric's show. So, John, why don't you start out? And I don't care where from that triangle you want to start out. What modeling is, the kind of modeling being used in confronting the coronavirus, or the relationship between modeling and policymaking. Start wherever you want, but why don't you get us going on this? Okay.
So there's lots of ways into this, as you said. One way is to sort of think about the role of a model. In the case of epidemiological models, just historically, I would say around in the 1920s or thereabouts, folks were thinking about the dynamics of epidemics, and they hoped to develop models that would explain the data that they had on past epidemics. So, for example, today we use, a sort of a standard model here is the SIR model. And the SIR model is the original model, the basic starting point for what are now called compartment models of epidemics. So they take the general population, they divide them, the set of people, into different categories. So in the SIR model, you've got the susceptibles, the infecteds, and the removeds. And your goal then is to track the dynamics of how we move, or how these agents or the people that we're studying move from being susceptible to infected, then removed. So you can be removed in a variety of ways. You could die, you could develop immunity, or you could be socially distanced. And as you know, effective social distancing effectively increases the number of removeds from the population. So the early SIR models basically track that dynamic in order to give an explanation for how the pattern that we see, let's say the early exponential rise in the number of infected people, maybe the peak and the leveling off, how would we build a set of equations? So in this case, it would be 3 ordinary differential equations that capture the SIR model in its simplest form, how that can be characterized in order to depict that dynamic. So that was the early goal in the 1920s. It was sort of an explanatory project to give an account of that dynamics. Much of what we do today builds on that. Now, there are lots of different kinds of models that folks in epidemiology use. There are these compartment models. So take, for example, the Imperial College model. That's a very, very fancy version of an SIR model with lots and lots of compartments, hundreds of categories, hundreds of parameters. It's not just those 3 parameters that we were talking about in the models from the 20s. So that's one kind of model, let's say the Imperial College style model. We have other models like the University of Washington model that's been very prominent recently. That's a statistical model. So that doesn't give any access to the sort of inner causal workings of the epidemic. It takes data, primarily the fatality rate data, and then curve fits to that in order to give predictions. In the same way, and we can talk more about the limitations of those various approaches as we go on, and Eric has a lot to say about that. So there are a variety of others. There are network models, there are agent-based models, there are combinations of those models. But bottom line is we're using models as the basis for informed decisions. So we want to reduce uncertainty. We've got models that sort of characterize the decision space in a way that allows us to reduce uncertainty and hopefully generate better decisions than we would have otherwise. So that's a very broad introduction, but it gives you the sense for the sort of space of different kinds of models and in very broad strokes. So,
Eric, do you want to add anything to that sort of initial sort of description or characterization?
Yeah, I mean, just to remind people of something they probably know, which is that the 2 models that John mentioned, the Imperial College model, that was the one that was used in the UK right after Boris Johnson recommended the herd immunity strategy that a lot of people criticized. And when some of the original recommendations were made in the United States, that was the model that said we'd get 2.2 million dead if we did nothing, but that with a maximum suppression, which was supposed to involve cycling the economy on and off, mostly off for the next 18 months until we got a vaccine, that predicted that we could reduce the death rate down to, I think, something like 250,000 from the 2.2 million. So that was one of the main models that informed policy here. And then it kind of...
The death rate from the virus, you're saying?
Death rate from the virus to Americans.
Okay, yeah.
It was predicted 2.2 million dead Americans from novel coronavirus if we did nothing, and I believe something like 200,000 if we did this maximal suppression. And then it also made various predictions about how the main reason that it was meant to reduce deaths was not because fewer people would get the virus over the period of time. It was because it would flatten the curve and thereby produce much less strain on the healthcare system, in particular on the number of ventilators. So the model did a lot of predicting about how many ICU beds we had, and it predicted that so what maybe a lot of people don't realize is that at any given time, most of our ICU beds are full anyway. Obviously, we don't just keep, we don't keep on hand thousands of times as many ICU beds as we need. And so the model predicted that, excess available ICU capacity would originally be, even with maximal suppression, would be overwhelmed by a factor of 8. But then after that, we would get it down, and then we would allow little waves that would just peak up to the available number of ICU beds, and we could kind of cycle that on and off until a vaccine was available. And then the other model that John mentioned is the so-called IHME model, which is from the University of Washington, which I think was funded in large part by Bill Gates's foundation. And that kind of piggybacks on the basic knowledge that we get from the kind of model that the Imperial colleges and the kind that John was talking about that goes back to the 1920s, because those models all produced these sort of logistic curves that we've all seen a million times now. And so what the IHME model basically does is it creates, out of a Gaussian, it basically creates curves that have that shape, and then just fits them to the incoming data. And so originally, of course, what they did, since the only data we had were from China, they kind of fit their curves to the, and so basically all those models really do is they have a moment when measures are implemented in society, and they figure out, based on looking at incoming data, what does a particular date of implementation of measures do to that curve.
Yeah.
And as everybody I think now knows, right, these things have gotten hugely, they get updated in huge amounts. So one day they'll predict that I think this happened, one day they were predicting that Alabama would have a deficit of 30,000 hospital beds, and then 5 days later, new data came in and they said, no, Alabama's not going to have any hospital bed deficit. But I think one thing we really want to remember is that the goal of both of those models, and it's so Wendy Parker has coined this phrase in the philosophy of modeling, but I've been kind of following behind her, chirping it a lot as well. Models are for purposes, and we don't evaluate models as being right or wrong. We evaluate them as being adequate for purpose or not. And I think it's important to remember that the purpose of both of these models was to both predict what kinds of strains hospitals would come under, but also to predict what we could do to alleviate that strain by implementing various measures.
Okay, let me ask you two things. The first question I have is, given that the second type of modeling, the statistical type of modeling, depends upon the first type of modeling, what is the added benefit of having the second type of modeling in addition to the first type of modeling in terms of our practical aims, our policy aims? That's the first question. Second question I have is, are the models flexible in the sense that if, as it seems to be turning out, we've been overusing or too quickly using ventilators, and they're now recommending not rushing to not using ventilators so quickly, are the models flexible in such a way that they react to that in terms of as an instrument for policy making? Those are the two questions I have at the outset.
Okay, I would say in principle they should be, and in principle we're going to be updating models given new data. I would also say that in my own work and work with others, we've emphasized actually the predictive role of modeling. So a good test of a model is its predictive power. So I think we're really in a space where what we mean by prediction here means reducing uncertainty. So we've got if you think about how we make good decisions, there are certain things we know we can rule out ahead of time. So we know we can rule out certain kinds of scenarios ahead of time, just via common sense. And then what the model does is it helps us to exclude alternative possibilities that are irrelevant to our current conditions. And that's going to happen through a process of updating. I think Eric might want to speak to the difference between the let's say the more kind of differential equations based models or the SIR style models and the statistical models. I think that there is a really interesting difference there that
Eric,
yes.
what's the benefit of having that statistical model on top of the earlier other kind, given that it depends on the other kind? What does it add to our decision-making abilities?
Yeah, so I think your two questions are very closely related. I think one of the purposes of the IHME model was that it is much easier to adapt it to incoming data. So the Imperial College model is a massive set of coupled differential equations, as John said, with 700 different parameters in it. The IHME model, they're updating every few days.
Does that mean it's clunky in the sense that it's harder? It's harder for it to adapt to new data in real time? Is that sort of the problem?
I don't know enough about the actual details of it. I don't know how much computer load it uses and all that, but I would imagine it's clunkier in that way. That's just a guess. But clearly what's the case is that the IHME model is being updated much more. It's being run on much more fine, so it's making state level predictions about ICU load need and hospital bed load need. And as I think John pointed out, that was its original function, was to help hospital administrators predict resource needs. I want to say one other thing really quickly about adequacy for purpose as a standard for evaluating models. So, I mean, I think one thing John said was, well, I think about models in terms of their having the purpose of prediction. I meant something quite a bit more fine-grained than that when I talk about adequacy for purpose. By purpose, I certainly mean things like, the purpose of offering explanation versus the purpose of prediction. But even with regard to prediction, that's not the kind of fine-grainedness of purpose that I have in mind, right? So predicting what? And much more importantly than predicting what? Predicting it, so different policy goals that you might be evaluating require very different uncertainty envelopes in your prediction. So, a model, for example, in climate science, a model that's designed to tell you, is it a good idea to reduce carbon emissions, right, is a different kind of predictive purpose than a model that's designed to tell you, is it a good idea to spray sulfate aerosols into the atmosphere to try to offset global warming? Or am I going to need to build a bigger dam in this particular? So different policy goals might all be asking models to make predictions. They might even be asking them to make the same predictions, but different policy goals might make the same model adequate for one purpose, but not adequate for another purpose, even if it involves them making exactly the same prediction. Because in some policy goal evaluations, an uncertainty envelope that's rather large might be tolerable, and in another context, that uncertainty envelope might be intolerable. So I think that's when I talk about models being evaluated for adequacy of purpose, I mean it in quite a fine-grained sense. Not just are you predicting versus explaining, but if you're predicting, what are you predicting? What are you going to do with that prediction? How tolerant are you to uncertainty? How good is your model at not just how uncertain is the model, but how good is the model at telling you on how uncertain it is? All of those things are, I think, extremely important when we're evaluating a model for its adequacy for purpose.
John, did you want to add anything to that? You look like you're...
I think I agree fully with that. We could talk a little bit about, let's say, if you have a model with a very large number of parameters, like the Imperial College model, we do have a question about the relevance of, the usefulness, let's say, of that degree of fidelity. So this might be a point where we could talk about expertise in epidemiology. So, for example, if you have some very large number of parameters, many of which won't have reliable data sources, and so we're currently in a situation where we have, we're in a low information environment about a lot of these very important pieces of evidence. Having roughly, I'm not sure exactly how many, but having roughly 700 parameters, many of which you don't really have good evidence for, means that we have to move to reliance on the expertise of epidemiologists. It might be the case then that in a lot of those models, we can simply do just as well by factoring out the points where the experts don't have, let's say, real evidence or real data, or are instead using professional judgment, that it's often the case that we can sort of have simpler, maybe less high fidelity models in terms of the number of parameters that are just as predictive. And a lot of these things, as Eric says, depend on, the purpose of the model. What is the model designed to predict? So if specifically our goal here is to reduce the burden on the healthcare system to a tolerable level, so we don't have the kind of situation in American hospitals that we saw in Wuhan. If that's our goal, and it's partly our goal, it seems to be our most important goal is reducing strain on the healthcare system, then we can often get away with lower levels of fidelity in the model. Maybe Eric wants to jump in here, but I think here so I'll leave it at that.
Eric, is there anything you wanted to add on that? Because I did have one more generic question about modeling and policymaking before we talk specifically about how it's playing out with the coronavirus. Yeah. As a general matter, so before we get to specifically how this is playing out under the current set of events, as a general matter, how do you see the relationship between this sort of modeling and the policy decisions that we ultimately make? In other words, the policy decisions we make are ultimately based in values, right? So, you just gave an example, if the aim of our policy is to unburden, not to overload the healthcare system. Well, one way you could do that, of course, is by killing everybody else in the hospital, right? So there's plenty of space. Now, we're not going to do that because we have a larger policy aim, right? Of not killing more people, not more people die generally than need to die generally, right? Not just from the virus, but from anything else. And so I guess what I'm sort of wondering is, do people have a misconception perhaps that there's a much more direct relationship between what the models tell you and what you should do than is really the case? Because the models simply give you information, but ultimately what that information implies in terms of what you ought to do depends entirely on the values that govern your policy making, right? Do either of you have feelings about that? Yeah, Eric, please go ahead. Yeah.
So really, really broadly, right? There are two ways you can think about how to make policy goals. I mean, and if you look at philosophy of environmental science and all that kind of stuff, this is just widely discussed, right? You can think of these things in terms of a kind of cost-benefit analysis, where you say, if I do this, there's a 20% probability of this very bad thing happening and a 40% probability of this not so bad thing happening. And I assign such a value to this bad thing and such a value to this not so bad thing and such value to this good thing. And then I look at this other policy choice and I look at the, I multiply the probabilities by my utilities of those things and I go ahead and do it. Now, of course, doing that requires you to make two very difficult judgments. One, how do I value these things? And two, what are these probabilities? Okay. And in particular, the second thing is often extremely hard to figure out. What are the probabilities of various outcomes given various decisions? So sometimes people think, right, and this is, I think, entirely justified. Sometimes people think when uncertainty is high, in fact, when sort of like what Knight called, uncertainty rather than risk. That is not just that not just that you don't know what's going to happen, but you don't even know how to evaluate the probabilities of how things are going to happen. And where some of the outcomes are really, really terrible, you should throw away cost-benefit analysis and you should just do whatever you can to avoid the really terrible outcome, right? That's so-called precautionary principle reasoning or precautionary reasoning or whatever. And they're very different, right? Cost-benefit analysis and precautionary reasoning are quite different. And precautionary reasoning doesn't really rely on as detailed a kind of scientific knowledge for obvious reasons, right? You just say, my God, this virus seems to have the, at least in principle, capability of killing millions of people. Let's just do whatever we can, right, to stop it. Now, if you, of course, decide to go that way, notice it's now very difficult to say, well, but what are the costs? How many suicides is this going to cause? How much domestic violence is this going to cause? How much, unemployment, and then, childhood hunger, et cetera, et cetera. How much is this going to cause other countries around the world that don't have stable political systems, like, let's say, Serbia, where, they have this sort of aspiring dictator who's now clearly using this to lock down, control the country. So if you go with the kind of precautionary reasoning, it then becomes very difficult to weigh the different options there. Yeah. So that then forces you, if you don't want to do that, if you do want to be able to weigh, virus deaths versus all these other things I mentioned, now you really need, right, some mechanism, some kind of cognitive mechanism for figuring out what those probabilities are. And there's no question, right, that once you want to do that, you got to do some scientific modeling.
Yeah. John, you're nodding.
Yeah.
One second, Eric. Eric, were you just finishing up, Eric?
Yeah, just one really quick point, right, is that models, I think, don't, in the end, give you the uncertainties, right? They're tools for experts to use to assign uncertainties.
Yeah, they just do what they do. Yeah. John, please go ahead.
Yeah, I am in broad agreement with what Eric's saying. That's eminently reasonable. I would say, even if we do assume a strongly precautionary attitude towards the epidemic, data and modeling are going to be critical anyway, right? Yeah. So let's say, for example, we're in a situation where we are capable of randomly sampling some sample of the population. Let's say we talked ahead of time about, what kind of numbers that would require in order to get just a snapshot of the folks who are infected now, or folks who have been infected, et cetera. So if we had a sample of 1,000 Americans at random, I guess that would be like a 3% margin of error. If we had 10,000 people sampled, we would have maybe a 1% margin of error. We need to be doing things like that give us sort of data via testing that are sensitive to these statistical constraints. Obviously, epidemiologists know what they're doing. They know how to run those kinds of tests. They know how to do those kinds of samples. But let's say we did that, and it turns out that 60% of us have had the disease or are carrying the disease. Then what we're doing currently would be absolutely pointless. But we don't, so there's no point in socially isolating at that point, right? We're not in that position. As far as we know, we're nowhere near that position.
Because we don't know how many people
we know some things. So we know, for example, that when expecting mothers are tested in hospitals in New York City, 14% of them are carrying the virus, right? These are small samples, maybe a few hundred people, but we do know something. We know.
Isn't it kind of an eccentric sample, though? I mean, is there any reason to think that tells us anything about pregnant mothers in Wyoming?
Oh, absolutely not. Right.
Yeah. Okay.
Right.
Good.
Absolutely
good.
not. Right. I mean, it is a sort of idiosyncratic group, right?
Yeah.
And as some people have pointed out, it might be lower than the general statistic in New York, in the tri-state area, because pregnant women are being very careful, or it might be higher because they're going to doctors' offices all the time. We don't know. We actually don't know. But having those kinds of measures, I think, is critically important. So this is just to re-emphasize the central point that even if you do take this maybe extremely precautionary attitude towards the problem, you're still going to need that kind of data. And then you're still going to realize that certain kinds of things are pointless. So if it turns out that there's a very high level of infection currently, which I guess we don't have evidence that that's the case, then even if we did have this radically precautionary attitude or value, it still would be a waste of our time and resources to socially isolate where we are now. So that's a hypothetical. I'm not saying that that is the case at the moment, but that's the kind of trade-off. So, there's something ghoulish, let's say, on first impression about a cost-benefit analysis in this space. Now, we do cost-benefit analyses all the time, right? Coal miners, we know how many coal miners are going to die to produce coal. We know how many people are going to die building a building.
Car driving.
Right. There is something deeply ghoulish about that, or let's say that's our gut reaction, is that it's a kind of a ghoulish calculus. But even if we're resistant to doing that and we want to be entirely precautionary and we're terrified of the virus for all kinds of good reasons, we still need good evidence and we still need to use models in this way to know what absolutely isn't helping.
Right.
So I just want to make clear one thing. I said, when I said, we can either do cost-benefit analysis or we can be precautionary. I think in the present context, what being precautionary would mean would be, we don't know anything right now. We need to lock everybody down until we have more information, until such time as we can start doing cost-benefit analysis. I think that would be pretty obviously the way to think about being precautionary here. Precautionary until evidence is better. Because of course, precautionary is always, I think that precautionary reasoning is always predicated on the idea that you don't know what the probabilities are. So of course, whenever you're being precautionary, I think this would be my opinion, whenever you're being precautionary, it behooves you to be collecting as much data as you can so that you can stop being precautionary, because being precautionary is never the ideal thing to be doing.
Let me just say one more thing, and then let's get fully into how the modeling is going with this pandemic and how it's being used in a policy making. I just want to make one other observation after what Eric had said. Eric, you very nicely pointed out just how difficult and complicated this is once your focus is no longer so narrowly on just preventing coronavirus deaths, but the larger policy value of minimizing deaths in general. Well, now you have to play off. You now need evidence and models of how many deaths are going to result from the measures that we're taking in order to stop these deaths. And you very nicely pointed out the complexity of that and the fact of the difficulty of getting all that other evidence that we would need. I just want to sort of make it a little bit worse. This all still only revolves around policy making that's based in what are essentially utilitarian values, right? If you now add on top of it the complexity of values like, for example, the extent to which we can have police interfering with people's free movement out in public spaces, right? In a liberal society, there is no science or data that's going to weigh upon that question at all, and there's no way to measure the relevant significance of that value as opposed to the utilitarian one. So I guess all that I want to say is that people should not think that there's some straight line from science to policy making. Right, the policy making is informed by values of multiple types, only some of which are informed by empirical science. Right, others are informed only by philosophical discussion or by religious.
Let me just add one.
Please.
We are still taking our shoes off at the airport. We are still bringing liquids on the plane. We are still running the PRISM. The Edward Snowden revealed snooping mechanism. So once you dial these things up, they are very hard to dial back. Things that when people give up these kinds of freedoms, right? We know policymakers are always very reluctant to dial these things back. And that's no science. I don't think there's any science of that. I mean, there's just maybe there's some sociology of that. I don't know.
Yeah. Some social science maybe would be relevant to that. John, did you want to weigh in just on these general observations about
it
modeling and policy, or do you want to go into the specifics?
This takes us pretty far afield. I do have concerns about, for example, the use of surveillance during the epidemic. But
we don't have to talk about that. I just wanted to point in that direction and say, look, on the policy side, we still have all kinds of things we have to work out that the science is not going to help us with, right?
Yeah.
All right, but we're here today to talk about the science, coronavirus, and policymaking. So let's now focus on that specifically. I don't care which review starts first, but could we maybe have you guys start talking about how the modeling is actually being used now with respect to the virus and the policymaking that we're basing on that modeling? How's it actually being done?
Well,
okay. Sorry, go ahead, Eric.
Yeah, so I mean, it's being used, I think, rather, in a rather simple and straightforward way. Namely, it's been used by politicians who've just kind of held up these pictures to us of these curves and said, look, so this started obviously in the UK. Boris Johnson had a policy choice that he favored. The Imperial College people came out with this model and said 500,000 dead in the UK. If you do this, 2.2 million dead in the US. And he very quickly buckled. You had, in California and Washington, the governors held up these pictures from the IHME and said, these are policy choices that, are going to produce these massive numbers of dead and these massive shortages of ventilators and ICU beds. And so these are no-brainer decisions. We obviously have to do these things because the models show these massive differences between outcomes.
How are they getting the information? I mean, look, Britain's a relatively small country. They have a centralized national health service. I'm assuming that data collection and everything is sort of systematized across the system. How in a place like the United States, which is enormous, in which states have a lot of autonomy and localities have a lot of autonomy, how is the federal government getting a sense? Are all these sources or all the hospitals around the country sending data to a central? How are we getting a national picture in the U.S.?
Yeah, so reporting.
I'm sorry, John. Go ahead.
Yeah, reporting is a really complicated matter, right? So that we don't have consistent standards for reporting, even something as straightforward as fatalities for the virus. If you look at reported data, you see all kinds of bizarre artifacts having to do with, updating software systems or the effect of Sunday, or holidays, et cetera, on the reporting rates. So there's a great deal of inconsistency, and one clear, I think one really important lesson of what we're going through will be that consistent standards for reporting across the country and across and internationally will be really helpful. So let's say we're interested in policy making and we're looking at the different levels of fatality in, let's say, Finland versus Sweden versus Germany versus Kansas. It's going to be really important that we know that we're starting from the same baseline with respect to evidence in order to make those judgments. So if we say, well, look, the Finns have N deaths, the Swedes have N plus many deaths, and the Kansans have very low rates. The relevance of that kind of data really depends on having consistency. And we currently don't have consistent international standards and, as you said, maybe national standards. But
how do we feed the models? What are we feeding into the models?
So it's going to be like county data from county health departments, data from states, press releases, et cetera. So if you're looking at what gets reported online, it's going to be like that. Of course, the CDC has close relationships with state and local health departments and all the rest. So we're in a pretty good position in the United States in terms of data collection. So It's not a simple matter, Dan. I mean, it's like, let's say, for example, I die of liver cancer, and they conduct an autopsy on me, and they find that I have the virus. Should I count as a fatality? If I'm in a car accident and I have the virus, then surely
obviously not, right?
But if I have a heart attack, then maybe.
Yeah.
And those are judgment calls that we leave to doctors, but they're going to vary from location to location. Whether or not we conduct testing on the dead in an autopsy context, that's going to vary from jurisdiction to jurisdiction. So having common standards would be really helpful, even if, we could quarrel about those standards, right? Having a sort of common baseline would be really helpful.
Eric, please go ahead.
Yeah, so one thing I noticed very early on, in New Jersey, there's a webpage you can go to right now. I think it's something like hippocrates.newjersey.gov. Don't quote me on that, but I think that's right. And it will tell you right now how many hospitals in New Jersey are not accepting any patients, how many are not accepting patients for the ICU, how many of them have broken CT scanners right now so that you can't, for example, get a CT scan if you go to that hospital. New York has nothing like that. It's been very hard to get information about what the seriousness of overcrowding in New York hospitals is. At the same time, there have been enormously many breathless articles in, the New York Times, the Washington Post, et cetera, about New York hospitals bracing for overcrowding, right? So that we then sent the Navy hospital ship to New York. They opened up the Javits Center with something like 2,000 hospital beds. They were throwing up tents in Central Park in Manhattan for more hospital beds. And again, I've been a bit disturbed by this, given that people are being asked, and in some cases forced, to make these very large, sacrifices to their livelihood and their personal freedoms. In the name of, as John has pointed out, right, where the primary goal here, and I think we need to keep our eye on that ball, the primary goal here has been to prevent hospital overcrowding. I'm uncomfortable with the fact that it's been hard to get good information on exactly how much of that hospital overcrowding there's been. Now, I know some of that, New Jersey probably had this system in place long before the coronavirus came, and New York didn't, and those are, in some sense, just luck of the dice or something, really. But it's made me uncomfortable that it's been hard to get these data, given that is
our main aim.
Yeah, it's our main aim. That's correct.
Right.
Yeah.
So I mean, the general point is that if your main aim is to reduce overloading hospitals, in order to feed the data into the relevant models, you actually have to know whether the hospitals are being overloaded, right? I mean,
I also think the public has a right to know about that. I think the public has a right to know how bad is this problem really, because we're being asked to make very important sacrifices and decisions about who else should make sacrifices, et cetera. We should have access to that information, I think.
Yeah, like and also, I guess that what they're doing also, it's not just about, more abstract issues, but they're very concrete ones. I mean, there are all sorts of elective surgeries and stuff that are not being done. Like my daughter was supposed to have a colonoscopy to see if she's got some sort of an upper GI, to see if she's got some sort of irritable bowel or something else, because she's been having stomach problems. That's just on hold indefinitely. So
sorry, moreover, right, we know that all across the country, but especially in the New York area, but even in San Francisco and Los Angeles, we know that, for example, cardiac patients in hospitals right now are down staggering numbers. I don't want to throw out a figure because I don't have it at the tip of my fingertips, but staggering numbers are down of cardiac patients. Now, there's no particularly good reason to think that the shelter-in-place things are preventing people from having heart attacks and strokes.
Yeah.
It's much more likely that they've seen all these articles and they're just terrified to go to the hospital. Now, we know that there are, for example, in Manhattan, we know there are a lot of excess deaths at home. What we don't know is whether those are coronavirus deaths that haven't been properly counted, or whether those are people that have been dying of strokes and heart attacks because anyone who's ever seen any of these public service announcements knows that some of the early signs of stroke and heart attack aren't obviously serious, right? We have to be told, if you have chest pains here, you should go to the ER very quickly because right? We don't know. We don't know how much of this is preventing people from seeking precautionary emergency care like that and making them die in their home.
Our hospital system just flat out told the entire county, don't come for, we will not accept you for elective procedures. Everything, my dentist closed. So it's not even just a matter of whether people are being spooked of going to the hospital. A lot of hospitals simply are not accepting any defeasible or contingent sort of procedures now. I guess, if you're in a car wreck and if you're bleeding to death, they'll still take you to the emergency room. But John. Yeah, go ahead, John.
I think, often I wouldn't want to criticize those kinds of calls that.
Oh, I wasn't criticizing. I was just describing it. Yeah.
But I will say, when we think about the costs of various courses of action, sometimes models also give us very clear insight into those costs and potential benefits, right? So it occurs to me, for example, when we think about the social costs of social distancing and closing schools, for example, we have ample evidence, both from past epidemics, from flus, et cetera, and from modeling data, that school closures are actually not, their effectiveness in preventing the spread of the disease is pretty small. So, and one thing is that it's a relatively small effect, but the other really important data point is that increasing the duration of school closure does nothing past 8 days. So there's
that seems counterintuitive. Could you explain why that is?
Yeah, I'm not sure I have a good causal story to tell about that. We could spin a story.
Could you imagine a kind of story that would explain something like that?
Complex.
Eric, why don't you go ahead?
Right? Complex dynamics are always counterintuitive.
Yeah, and it's often, sorry, Eric, but households seem to be an important vector. So a lot of spread happens in the home. So
you're locking everybody in the home more, and that's where the primary spread is happening. Is that the issue?
No, not at all. So maybe Eric, do you want to talk about that evidence? So
I don't have anything to say about the particular explanation of this. I want to remind people very strenuously that your intuitions about these things are useless.
Are terrible, yeah.
Even experts. So, I could give you lots of stories of scientists I've talked to in climate science or in astrophysics or whatever, who run simulations, who think, if I tweak this parameter in this direction, it's obviously going to have this causal effect downstream. It does just exactly the opposite.
Yeah.
Complex systems are not suitable to you reasoning about it a priori or consulting your intuitions about
it. But it is important. It is important in terms of, because at the end of the day, you do have to persuade the public, right? And so I guess what I'm asking you is, could you tell me a kind of a story that would make my intuition go, oh, okay. You know what I mean? I get that. You know what I mean?
I don't know in this case. In this case, I don't know, and there may not be one. I don't know. But maybe John could say something more.
Yeah, because it sounds, on the one hand, you're saying, it may be effective to not have people going into stadiums, right, and hanging out, but people going into schools, well, that's not effective. You know what I mean? I guess, if the principle then isn't we shouldn't have large gatherings, then what is the principle, or is there no principle? Is it actually a much more dicey, particularistic kind of? John, do you have any thoughts on?
Yeah, I'm not gonna spin a story about that. I'm not an epidemiologist.
Yeah.
I'm going on what the review of the modeling and the evidence tells us.
So what it shows us is that it works up to 8 days, sort of, and then after it doesn't work at all. But we don't know why.
Have any effect? Extending the school closure beyond 8 days doesn't seem to have any effect.
I should say that when I pointed this out to some people, there is a reply, which is, well, we don't know what school closures do in conjunction with these other measures because we've never done that. So
Yeah,
Anyway,
there's always going to be a reply like that just because of the number of variables.
I mean, the point of that, the point of raising that particular, fact is that the young are bearing a heavy cost during this, and we do have some responsibility to recognize how difficult it is for children and young people, and we shouldn't take that lightly, right? So closing the schools, I think, was a prudent measure at some point during the pandemic. It might not be a prudent measure going forward. Yeah. So in the case of our own industry, the universities, the talk of keeping the universities closed, we should weigh that very carefully. I know that in China, for example, they're maintaining the closure of universities and colleges because they're worried about transmission geographically, but they're beginning to open the elementary school because there's no fear that people are going from province to province to go to elementary school. So there's a lot of factors there that, as you said, as you and Eric both said, aren't straightforward cost-benefit analyses. But I think, responsible consideration of the harms that other people are suffering because of this is it's incumbent on us to take that into account, especially if we have evidence that says, well, it's not clear that what we're doing is any good. So if it's
Yeah, so just to note one thing, I mean, so Denmark, where I think some of the best science, some of the best random testing, et cetera, so they reopened schools yesterday for kids up to 9 years old. I think there's probably very little harm to kids over that age being kept out of school. They'll be fine. That's my completely uninformed opinion about that. But yeah, I mean, especially for kids that, then are putting a burden on their parents, not if their parents are healthcare workers or work in other essential services or whatever, having kids under 9 have to stay home. Obviously that has high costs. Yeah.
I think as the parent of teenagers, I would say that not being able to go to school is actually a real harm.
Well, the cost is tremendous. I mean, listen, my daughter is graduating high school now. She's going to have no graduation. She's going to have no prom. I don't know what price you put on once in a lifetime experiences. I don't even know how to measure that. That gets back to that earlier issue about policy and about, the sorts of values that are not informed very much by any empirical science. And she is very excited about beginning university next fall. She's been accepted and has accepted an offer to go to the University of Indiana for vocal performance. It's not clear that that's going to happen, right? I mean, it's not clear, and so these things do really matter. Obviously, people dying of a pandemic really matters. And obviously navigating all that purely from a value side is extraordinarily difficult. But it's something that we have to do. I mean, and that policymakers have to do. And so let me ask you, just to keep this back, because we didn't want to have primarily a philosophy and values discussion. To the extent to which it seems like you both have concerns about how the modeling is being done and used with respect to the policy making about the virus, maybe you could articulate what some of those concerns are. Eric, you want to go first since you're
so I mean, here's I think one very broad brush kind of concern that I have. So I spent a minute a while ago explaining the difference between kind of cost benefit analysis and precautionary thinking about policy. And my worry is that particularly with a model like the Imperial College model, where there's 700 parameters, many of which are unconnected to any real data, modelers have enormous flexibility in having the models come out in a variety of different ways. And I worry that rightly, epidemiologists are going to be cautious here. They're not going to want to say all's clear when it isn't. Okay? That's justified on their part. They should do it. They were right to do it. But I worry that precautionary reasoning is getting paraded as objective modeling, so that what's really going on is people are thinking we better be cautious. But rather than coming out and saying that, what they're doing is they're producing scary models that then have the rhetorical power of convincing other people to be cautious. Now, I worry about that even if the precautionary reasoning is justified. And I worry about it for two reasons. One is I worry about the effect it's going to have on the credibility of science if you parade out models that end up looking really bad. And the other is I worry that there's a difference between, maybe it's three things. It's like the Spanish Inquisition. There's three things. The second is you are making value judgments for other people and you're hiding them in what looks like something objective. But then I think even worse than that, maybe, when you do that, right, when you parade out these models that say absolutely very little uncertainty, 2.2 million dead in the US if we don't make these measures, I think it then becomes very hard to dial that back. So I think if you do that, if you parade out a model that says 2.2 million dead without measures, but then new data start coming in, right? Data like, let's say, the pregnant women study in New York, which I think probably tells us that something north of 30% of New Yorkers have been infected. As new data like that comes in, it becomes, I think, harder for both policymakers and the people who inform them to then say, oh, you know what, that wasn't really a well-informed model because we didn't have really good data. Now the new data are in. And this is, I think, what you see happening in places like Denmark and Germany and Austria, is a kind of flexibility that we're not seeing here. So, I think some of those Central European countries are behaving in a way that I wish we were behaving more like. And I worry that in part we're behaving that way because we tried to, mask precautionary reasoning into cost-benefit reasoning or something crudely like that.
Yeah. So here's where I think we would differ slightly. I think I certainly wouldn't ascribe, and I don't think Eric means to ascribe the intention, right.
No, I didn't take it that. I didn't interpret that way. No.
Right.
It's just a natural. I think it's a natural dynamic. I think it's a natural dynamic.
I would say
one policy information or whatever.
Yeah, I mean, one of the problems with public discourse around policy in the United States is, the quality of how people receive their information, the quality of journalism, the sort of excessive kind of entertainment quality of American politics, that it's kind of sports or entertainment driven or tribal or whatever, that, we lock on to, and maybe this is another way of putting your point, we kind of lock on to those models, the early models, emotionally or psychologically, and we tribalize them so that if people are getting on the internet and criticizing the models, then they're with the bad guys. They're with the Trump crew, right? They're science deniers or whatever. And so I think that kind of excessive, this is another consequence of the polarization of American public discourse, right? So I
had a whole conversation with Robert Tallis about his book Overdoing Democracy, about this polarization.
Right.
Yeah.
So the difference is that we're not in a position to sort of wind back and say, okay, we overshot the mark or we misinterpreted. And then the other side of this is that, this is an old point from economics that, was it maybe my memory's not serving, but I think it was Morgenstern talked about you generate a successful model in economics and you immediately make it false because people act on it.
Yeah.
Right.
Yeah.
So if you generated these terrifying predictions and then people acted in response to them and thereby falsified the predictions, that wouldn't be a vice of the model. That would actually be the model doing exactly what it's supposed to do.
Right.
So those kinds of traps, though, trap is the wrong word, but we should be in a position to revise our view. And I think what Eric's concern is, I would say it's not so much that the epidemiologists are excessively precautionary. They probably are, but the real pathology is the way that these headlines get used and the way that people latch on to the headlines and then defend themselves by saying, "Oh well, I'm listening to the experts, and how dare you, philosophers, epistemically trespass on the pronouncements of experts." So I think that's where we have to be careful. We have to maintain a level of skepticism. I mean, I think epidemiology is a mature science, but we're in a new situation with respect to the virus. And, you know, a lot of these modeling questions are general questions. They're questions in philosophy of science that people have been talking about for decades, and that are open for criticism from philosophers of science and other, even economics, right, has the right to look at these things and be skeptical about what the models are telling us. That doesn't mean that we can live without models, that we can make decisions without them, but it does mean that we don't just immediately defer.
Yeah. But I just really quick want to say,
no, please, yeah.
John, you said that I said that they were overly precautionary. I didn't.
No, he said they're supposed. You said they're supposed to be.
I said they were rightly being precautionary. I said they were rightly being precautionary. Okay. What I was saying was, when you have 700 parameters to adjust, and you're in a situation where it behooves you to be precautionary, nobody should be surprised. Nobody should think this is bad on their part. Nobody should be. It's a natural feature of that dynamic that parameters are going to get chosen that motivate precautionary reasoning on the part of the policymakers. I just think that's just what you're going to get when data are poor, parameters are unknown, perturbed ensembles aren't available, all the things that, you know, when you have 30 years like we've had in climate science that you're able to do, that you're not able to do in this situation. I think it's just natural that people looking, you know, a virus down in the face that might kill millions of people are going to think, look, this is a moment to be cautious. I think that's entirely justified. I just worry that it gets packaged then in a way that makes it unsuitable to being revised.
Sure. Let me just clarify the point then. I think I can agree with a lot of what you're saying, but if we're looking at the difference in reception of epidemiology across countries, then that's a cultural difference. It's a difference in the quality of public discourse, and so presumably that's all I would say.
Yeah, let me just, because I interpreted Eric a certain way that I think. I don't think there's actually any disagreement between you. I mean, the way I interpreted Eric was that if we are currently witnessing a failure of some kind, it's entirely a failure of political leadership in the following sense, right? So look, before maybe we made what seemed like too hard of a distinction between, on the one hand, the empirical science modeling on the one hand, and then the value-informed policy making on the other. But as Eric just rightly pointed out, there are values presupposed within the scientific modeling, like you said, one thing being the precautionary principle that any responsible epidemiologist would take on board. And so the modeling is going to reflect that, right? That's all how it should be. It strikes me that the problem now becomes when the political leadership simply takes that on board as a straightforward instruction, as opposed to taking it as one point with a presumptive valuation that is precautionary, but failing to now consider it in conjunction with other value considerations other than the precautionary. And ultimately, I think, in my view, if you were to ask me, this is the result of our political leadership having become unwilling to bear the responsibility of leading, right? We don't hire the epidemiologist to lead. We elect you to lead. The epidemiologist gives you a set of information that is itself presupposes a certain value, right? That is precautionary values, right? You as the leader now have to take that and weigh it against all the other values that need to be considered that the scientist has nothing to do with, right? And then make a policy. And it seems to me that if there's a failure here, we're going straight from the modeling to the policy without the political, and the political leadership part is missing. That's what seems to me to be what comes out of Eric's. Now, I don't know if I've got that wrong, Eric, but
I think that's right. And I think, look, the situation is not helped when maybe we're drifting a little bit afield here, but the situation is not helped when we have a president with a probably well-earned reputation for being, dismissive of science, and then it immediately scores political points for anybody in a state that's generally leans away from Trump to say, look at us, we are just the unabashed, agents of good here because this is the Manichaean struggle between one party that hates science and another party that just does exactly what the scientists say we should do or something.
Yeah.
When this is all nonsense, right? I mean, there's no such thing as politicians, as you've been pointing out a number of times. There's no such thing as politicians doing what the science says. That's not
right. There's politicians doing what the values say, and the science provides information that's relevant to one set of those values, but not all of them, right? John, do you have any feelings about my characterization of Eric, and what if there's a failure, where the failure is, and that it's a failure of leadership, political leadership being willing to lead in a sense?
Well, I'm not sure. I think if you're asking me about the quality of political decision making in the United States, I think it varies widely from state to state. Obviously, we've got the Trump administration, which is a bit of a disaster. But I'm not sure. I think, for example, in our own state, in Kansas, or my state, Kansas, we've actually got a really excellent political leadership, and I think our governor has been very prudent, very careful, attentive to the science, and maybe what characterizes her dispositionally is that she really doesn't care about getting reelected. She's a responsible public servant.
Yeah. So then, John, what is your concern then? What is your concern? I mean, because Eric pretty clearly voiced what his was.
Yeah.
And he had several. What concern then do you have, if you can articulate it? Is it about the modeling in itself? Is it about the way the modeling is being used by policymakers? What is your main concern?
Oh, well, I mean, I think my principal role in this discussion is to maybe clarify some of the kind of core points about the role of what models are for, what can they do, how do they get integrated into this public policy decision making. That's all. I don't have a specific gripe against beyond the sort of the obvious gripes that one would have about these things. I think that there are unexplored options that we can look at. So, for example, we talked about the school reopenings. We talked about the sort of the basic arithmetic of keeping an eye on the target being, preventing our hospitals from being overwhelmed. If we keep an eye on that target and design policy around that, then there's lots of options. There's lots of ways to reopen that are sensible, that can avoid that kind of spread. In terms of the rhetoric and how we present this to the public or how the public understands it, you could say, for example, look, we're all going to get this virus at some point over the next few years. This is a virus. It's like the cold, it's like the flu. We're going to get it. We don't have any immunity. It's a novel thing. It's going to course through our population. You're going to get sick at some point. It's just a matter of timing when people get sick and organizing ourselves in a way that, the pace at which people get sick doesn't overwhelm our institutions, our important institutions. that's a kind of recalibration, or maybe a reminder of where we started at the beginning of this outbreak, which was with the target of so-called flattening the curve, right? That was all we heard about for the first couple of weeks, is flatten the curve, flatten the curve. If we can kind of remind ourselves of that target and then reopen with that in mind, that might be a helpful path forward.
How have we done that with other communicable illnesses? You know, how have we in handling, let's say, influenza, prevented systems from getting overwhelmed? What have we done? Now, obviously, we have a vaccine, but there are years where it's the wrong one, right? I mean, there are years where it's not particularly effective.
There's obviously, well, Eric can maybe speak.
Well, look, so for one thing, the flu isn't a novel virus,
right? But it was at one point, right? I mean, it never was.
I mean, there must have been something going on in 1918. I'm not an expert. I don't know. But look, we have had hospitals get overtaxed because of the flu. They were massively overtaxed in Germany in 2017-18. There are stories you can read if you look in the local presses of Los Angeles and Dallas, also 2017-2018. You can see pictures of tent hospitals in Los Angeles because the flu was overtaxing our systems. Now, of course, it was nothing like what we saw in Italy or what we saw in Wuhan.
Right.
But it's happened, and it's to the best of my knowledge, nothing has happened in the United States that has been an order, a genuinely qualitative order larger than what we've seen before in the United States.
In terms of periodic overwhelmings of a system by something that's particularly virulent or so there is no way, in a sense, to prevent being overwhelmed. What happens is you periodically get overwhelmed, and then hopefully you adjust in your systems and everything so that the next time you get overwhelmed, it's not quite as bad next time.
And look, there's a sort of libertarian point here that I only sort of half-heartedly endorse. And that's that if you look at the data, people are pretty smart. When they see people dying, they don't, they start washing their hands more and wearing masks and not going out as much or whatever. And if you kind of look at some of the data around this viral outbreak, you can kind of see that people were already doing some of the things that governments began mandating before the government mandated it. And that, of course, has the advantage that nobody needs to get arrested. Nobody needs to, et cetera, et cetera. So right. I don't have a strong view about whether that claim is correct or not, but I do think it's worth thinking about the extent to which people are smart enough to kind of bring about most of the benefits that you're going to get from this without the need for government intervention. I don't know.
John, I have a question. You said before, this notion of a smart model-informed ways of trying to reopen, so to speak, like the elementary school case you gave an example, and others. I guess the question I have is, John, but are we collecting information sufficiently and in the right ways to feed the models such that we can trust the answers that we get out of them, I guess, is what I'm asking you, John, since that was your focus, was more how we use the models to make the policies. And you gave this example of elementary schools reopening. Are we feeding the sufficient and the right way information into the models such that they're going to help us in that regard?
Well, look, there's lots of people working on these things and doing a good job trying to do that. I think obviously testing is critically important. So, I mean, everyone's saying testing, and I would just agree. I think, and I mean, the other part, I don't want to repeat myself, but sort of consistent measures, consistent reporting, that's really important. So, if we're flying blind, then we're in trouble. But we're slowly gathering. I think the lesson of this will be to increase surveillance, increase consistency, and I think we'll get there.
Seems also like communications is very important in terms of getting all the different parts of the country and all the different localities and everything where there's a reliable and consistent giving of information to, let's say, the CDC or whatever the central, so that when we make national forecasts, they're actually based on sort of given the wild disparity between places like New York City and Wyoming, let's say, in terms of population density, et cetera. We really do need information to be coming in consistently from all these different areas to get an accurate national picture. Is that not correct?
I mean,
yeah, I think constructing that kind of surveillance mechanism or those kinds of institutions is a relatively cheap way of helping us guide policy going forward. And given the deep costs, the sort of dramatic costs of this, I think we will see the development of those kinds of institutions and strategies. Those systems.
Imagine if this thing had played out from the beginning in such a way as you could have all along gone to a web page which would have told you the rate of infection in every state, would have told you how many ICU beds and ordinary hospital beds were available in every county in the state, et cetera, et cetera. Imagine the quality of judgment that we could have been making about this.
So there is no such database with such information, is what you're saying.
Look, so there's no database about the hospital beds, and there just hasn't been anything like systematic testing. The best American information that we have comes from in my opinion, I've been looking at a lot of this. The best information that we have about the United States rate of infection comes from this study of pregnant women in New York City. I mean, that's crazy. Why are we shutting down 30% of the economy, putting 30% of people out of work, but we're not just doing some basic random testing of people so that we know what the rate of infection is in every state?
Well, do you have an answer to that why question? Good or bad answer, but do you have or a guess as to why you think we're not more aggressively pursuing the data accumulation?
I don't know. That I mean, of all the sort of poo that I could throw at I mean, this is just scandalous. This is just criminally immoral that we don't have this information. I don't know who entirely is to blame for it. I don't know whether it's the CDC or Trump or the governors or whatever. I don't know enough about the ins and outs of all of that. But it's just not acceptable that we're not finding this stuff out, which is not that hard to find out.
Could it just be, though, Eric, as a result of the massive decentralization of the entire system? In other words, that we don't really have a system. What we have is a patchwork of locales with their own systems, and nobody ever really sort of put it all together and tried to create a national database.
That's for the hospital bed stuff. I think that's probably right in that case. But why is Governor Cuomo not doing this? Why is Governor Newsom not doing this?
You mean the testing?
The testing. Just telling us what the underlying rate of infection is. It's not okay that we don't know that.
John, do you have any insight as to why that's not being done, or?
I have no insight as to why it's not being done. I mean, I don't want to repeat myself, but I gave a kind of similar defense of the importance of sort of figuring out the current rate of infection. Even if it's just a snapshot, it would be helpful, as Eric is saying.
Yeah.
And it actually wouldn't be that expensive. It wouldn't be. Now, maybe we're wrong somehow about the epidemiology or the value of that kind of community probe.
Yeah.
But it certainly needs serious consideration, as Eric is saying. So I mean, we should be doing it. They're doing it they are doing it in different countries. So I guess Korea had something like this. The Germans are doing something like this. Iceland on the 14th of March or 15th of March had something like this.
Denmark has
yeah. I mean, it wouldn't be that expensive, and it wouldn't be. I mean, it would at least give us a snapshot of where we are, and so those are. I agree with Eric. Those are the kinds of data that we really should be getting, and there actually are, I think, some studies that have been started along those lines. But I don't know what the progress is at the moment.
Okay. I mean, is there anything that either of you gentlemen want to add to the discussion on this? Not that this doesn't preclude us from having future discussions, but is there anything we haven't touched on that you want to discuss?
I think I've gotten most of the things that I wanted to say.
Yeah, I think it's certainly the case that the disease has exposed all kinds of weaknesses in our social system, in our political system. It's also exposed a kind of weakness in our capacity to deliberate about these problems publicly. So there's lots to be learned. I think we also need to be, obviously should go without saying, we need to be sensitive to the harms that result from any decision we take for vulnerable people. So I think the effects on the young, the effects on marginal populations in the United States are things we should take into account when we make these kinds of sweeping decisions around closing the economy down, et cetera. And
I'm not sure
that's
been mentioned, but also the effects on victims of domestic violence, I think here could be.
That's being reported on in the UK. I've noticed there's been quite a bit of reporting on an apparent increase in domestic violence in the UK simply because I don't know if I haven't seen really quite as much reporting on that in the US, but in the UK there's certainly been.
I've seen some in the US, I think.
Yeah.
Look, I mean, come on, you bottle people up in their homes for weeks on end. People who are, I'm not saying it's going to cause ordinary people who wouldn't normally commit domestic violence to do it, but we already have a fairly large problem with that, and it's just clear. I mean,
yeah. It's funny that's why I was sort of stressing. As you rightfully said, it is the rightful aim of epidemiologists to operate on the precautionary principle of preventing as many people as possible from getting the disease. And overburdening systems, but it's got to be the aim of policymakers. The aim of policymakers has to be broader and more general. It has to be the overall not harming of the public, of which this is one variable, but of which all the remedies implications may also themselves be variables. And I think that everybody kind of knows that, and this maybe gets back to what John was saying. And that part of the real problem here is that we have a real problem in public discourse and communications, is that you cannot even have these conversations at a certain point because people employ them in all sorts of partisan and tribal and other stupid sort of battles that make that sort of conversation impossible. But it's a conversation you simply have to have. I mean, I've been saying all over social media that, look, there's simply no way the public will tolerate 18 months of a lockdown. If you try to impose it, there will be mass civil unrest and riots, right? And so you're going to have this conversation at some point. It's just a matter of when, and it's just a matter of how painful or pleasant the conversation is going to be. But you will have this conversation.
And very little of the discourse, I would note, very little of the discourse is reminding people, as it needs to do, that this is a marathon, not a sprint. Right?
Yeah.
We are not going to deal with this, by the end of April or by the end of May or by the end of June or by the end of 2020 or even by the end of 2021, most likely. Right. So this is, as John, I think, has emphasized a number of times, this is a virus that is going to work its way through the American public one way or another until we have a vaccine.
Right.
And let's not be overly optimistic about what a vaccine like that is going to be like. It's going to be, I would guess, at best as good as the flu vaccine we have now, at best, given that we've had, decades to refine that vaccine. So this is definitely a marathon, not a sprint. And I don't think a lot of the public discourse about what kinds of measures are warranted is taking adequate cognizance of that fact.
Well, and one variable that's not been mentioned at all, and that obviously affects the whole calculus, which we just don't know, is, aside from a vaccine, will we be able to develop treatments that will meet? Because right now, if you get it bad, you're really fucked, right? I mean, it's sort of this weird schism between either you get it and it's not bad at all, or you get it and you're totally fucked. I'm assuming that treatments will start to develop in which the people who get it won't be as completely fucked, so to speak. And we just don't know that, right? We just have no idea what or when treatments that will mitigate the effects of those who have it and maybe thereby make having it bad more survivable. We just don't know any of that, right? Yeah.
I wouldn't hazard even a guess as to
and that's another variable, right? I mean, that's going to be have a huge impact on policymakers because look, even though this may take years and we may never get a vaccine, if we have effective treatments that getting it is not like going to kill you immediately if you get it bad, we might decide to reopen up sooner rather than later, right? And so we just don't know. So anyway, well, thank you so much. I really appreciate the conversation, and I think it's an important one to have. And like I said, we will be having it whether we want to or not as this goes longer and longer. And so I want to thank both of you very much.
Thank you very much for having me and us on. Yeah, it's been great.
And maybe as you think, are you guys working on, John, you mentioned something about that you guys are going to do something together on this, like an academic something on this paper?
Well, hopefully.
Oh, was that, had you not broached that with Eric yet?
No, I think we talked about it briefly, but there's just so much going on, and I think things are moving quickly, and Well, if you guys do get together or do have some, work that you want to do together, I'd love to have you on again to talk about it. So, thank you so much. Thanks, Dan.
All right.
Thank you.
Take care.
All right. Everybody stay safe.
Everybody stay safe and healthy. That goes without saying.
Yeah.
All right. Take care.
Okay.
Bye-bye.